Ready?
Yeah. All right, I think we can go ahead and get started. Am I live, Myra? Am I live? Okay, so I can't cut. Got it. Okay, so welcome everybody to Grand Rounds. It's my pleasure. I'm Davey Smith, by the way, and I am the speaker's friend and colleague, Sara Gianella, who we worked together for how long we worked?
16 years.
16, and she's counting every day.
And 3 months and 15 days. Yeah.
So I'm super excited to she's published 170 some odd papers and has thousands and thousands of citations, and she works in many different areas, mostly related to HIV and HIV reservoir and co-infections, and is a big, fierce advocate for training and diversity and inclusion. And it's been an honor of my career to have these 16 years and 3 months and 45 days working with you. And I'm sure we're going to have a really good talk. So thank you.
And so thank you, Davey. Let me just say, okay. So I do wear many hats and I do quite a bit of work, but there is one topic that is very close to my heart. This is how I started, and this is something that I have been really consistently working on my entire career since I came here, and it's trying to understand the interplay between cytomegalovirus and HIV. And it also makes me particularly proud because it doesn't happen often as a researcher that you have a story that you start at the bench and then you carry it all over until the clinical trial. And this is where we are right now with our CMV story. So it has been like 16 years of believing the story, publishing and advocating, and then getting the clinical trial, and now we have the results, which I think are really excited. And so I'm excited about our next step. So what is important to know as a background is that life expectancy gap for people with HIV has been now narrowing thanks to all of the successful antiretroviral therapies, but it's not completely zero, right? In average, we still have about a 9 to 10 year gap between people with HIV and between people without HIV. And this gap is particularly relevant for people that either start antiretroviral therapy later or have low CD4 T cell counts. And here you can see, right, people that have lower CD4 T cell count have a larger gap, and they also have a comorbidity gap. This means that even if people live longer lives, they also develop more comorbidity like cardiovascular disease and cancer and diabetes and all sorts. So the quality of life is not to the same level. So one factor that we know is a very strong driver of comorbidity, in particular for people with HIV, is inflammation, right? We know that people with HIV, no matter how early they start antiretroviral therapy, and even when the immune system reconstitutes, they still have some chronic inflammation going on, which persists for the entire life and strongly predicts morbidity and mortality. So here are some of the data. There are multiple papers showing the same concept, but you can see here, right, when you stratify participants based on IL-6 level, higher the IL-6 level, shorter is the time without comorbidity. And really, we as a field, what we would like to do is try to get as many people as possible from the top 2 quartile into the bottom 2 quartile, so that people can live long life and also not have all of this disease that are impacting population health. So there are some data, that from people without HIV that point also in that direction. It's a little bit less clear, but for example, interleukin-1 beta has been an inflammatory marker that has been studied extensively, especially in the cardiology field. And there has been a clinical trial showing that people that were taking an IL-1 beta inhibitor had a lower risk of cardiovascular events and cancer death. It's important to note that people that were taking this IL-1 beta inhibitor also had increased risk of dying of sepsis, which it's not surprising because obviously there is always a balance when we intervene on the immune system, right? On one side, we don't want the inflammation that is damaging. On the other side, we do want the immune response that can keep all of our infectious disease on check. Go to the next. So it has been a while now that the HIV field has been trying to reduce inflammation. And in fact, the AIDS clinical trial group, which is a large network that is running clinical trial, has a whole group of people that is dedicated to finding way to reducing inflammation. And I have been part of that team now for also over 10 years. And many approaches have been tried, unfortunately, not very successfully so far. I will say recently there have been some promise with the mineralocorticoid receptor antagonist, which is antihypertensive that apparently has been shown to reduce inflammation. And the GLP-1 agonist, which right now seems to be, the one medication that is curing everything. There has been a few trials in people with HIV where they have shown reduced inflammation. And, this will be somehow probably there will be future study to confirm. I think that the big breakthrough has been Reprieve. And I don't know if everyone is familiar. Everyone in the HIV field for sure is familiar with Reprieve. This has been a huge phase 3 trial where the ACTG has been enrolling over 5,000 people with HIV that were at low risk of cardiovascular disease. So these are people that usually wouldn't qualify for a statin. And people were randomized to get statin versus placebo. And the idea is, does statin, even in people that usually would get it, improve cardiovascular disease? And it was a large trial. It was done, internationally, and it was then ended early because when they did an interim analysis, they were able to show that there was a huge decrease in cardiovascular disease. And so the trial was stopped and everyone was then put on statin. There was no significant effect on cancer and other aging-related disease, and there was a slight increase on diabetes. So that's worth noting. What's also important to say is that this statin effect, this didn't seem to be linked to a decrease in inflammation, but it was mostly a decrease in lipids, right, as expected. So despite the fact that this was great and has informed a change in the practice of how we treat people with HIV, and now everyone or many more people get access to a statin, it really seems like there is a residual risk due to inflammation that is still not addressed. Okay, and so this is where CMV comes in, right? Can it be that replication of cytomegalovirus, which is a herpes virus that almost everyone catches early on in life, and especially people with HIV that have usually an increased risk profile, I will say 90% or even higher of people with HIV also have cytomegalovirus. And we know that it kind of really likes to evade the immune system and bubble in the background and engage the immune system and cause inflammation, right? And so it has been over time kind of a lot of people have thought that maybe CMV has something to do with inflammation. And this has not only been in the setting of HIV, also in other settings. And now getting back to some background, and here is, some of these data are the work that we have been working on since 10 years, right? Like here, for example, our data that we collected sample from people with HIV that are part of Susan Little's primary infection cohort. As part of this cohort, participants have been donating genital secretion, and we know that genital secretion is a big reservoir of cytomegalovirus, where the virus likes to replicate. And over time, if you follow people for a year, almost everyone had some sort of cytomegalovirus or EBV replication. This means that people with HIV, even if they start antiretroviral therapy early, even if they are caught during early infection, they still have CMV and EBV replication going on, and they completely asymptomatic. We also know that cytomegalovirus elicits a massive immune response. These are data from Louis Picker, and they can show, and it shows that people that have CMV compared to people without CMV have 4 to 9 to 10% of their entire T cell repertoire that is targeting CMV. This is more as people get older, and it's even more in people with HIV. So there is no other virus that we know about that is able to engage the immune system at this level. And you can imagine, right? Like when the immune system has to keep fighting the virus to keep it under control, and the virus has been living with us for, basically the whole humanity. It also became very smart about how to evade the immune system. So it's really a dance between the virus and the immune system to try to keep it under control, and the virus starts to come back on, and that's for your entire life, right? And so basically having CMV your entire life kind of skews the whole immune system and T cells towards trying to fight CMV. So some interesting finding, again, data that we generated, but really many other groups have generated, that CMV is not only able to elicit a CMV-specific T cell response, but really it also creates a huge bystander effect. So people that have cytomegalovirus, they have increased IL-6, they have increased soluble TNF receptor 2, they have increased CD8 T cell count, right? Like CMV is really not only engaging the T cell that really go against CMV, but everyone else too, right? It really creates a big bystander effect. And I do want to, take everyone's attention on soluble TNF receptor 2, because this is one marker that we found in one of our early papers to seem to be specifically increased in people with CMV, but not so specifically increased in people with HIV. And I wanted to point it out because, fast forward many years, when we designed our clinical trial, this is then the marker that we used for our primary outcome. So, and there is also a lot of literature linking CMV and this surrogate marker of inflammation to various comorbidities. And the vast majority of this study are observational studies. So there are multiple confounding factors, obviously, and we cannot really be 100% sure that cytomegalovirus is the driver of cancer or cardiovascular disease or neurologic complication, but let's say there are multiple hits over time that it looks like people that have CMV and people that are actively replicating CMV seem to have increased level of all sorts of comorbidities. And I just wanted to show you some of the data. Like, for example, this is a large cohort in Italy where they compared people with HIV with and without CMV. And this means people that were seropositive and seronegative for CMV. And they showed that there was no difference when looking at AIDS defining events, but there was a difference when looking at non-AIDS defining event. And this difference was particularly large in when looking at cardiovascular disease. These are data from Priscilla Xu, that at the time was at UCSF. Recently, she was recruited to be the chief of cardiology at UCLA. And she also was able to demonstrate that in people with HIV, there is a positive correlation between CMV-specific CD8 T cells and some surrogate marker of cardiovascular disease, like mean carotid intima media thickness. Again, pointing that there might be some correlation between CMV and cardiovascular disease. These are data for cancer. Like this is a little bit more recent. It does look like, at least for some of the cancer, there is an increased risk in people that have CMV, or even people that seem to have a higher CMV-specific immune response. And these are data from our very own Scott Letender, who is a professor here in our division. And he has been showing that people that have higher CMV IgG titer were associated with worse neurocognitive impairment in the setting of treated HIV. And this is, again, is something that has been shown in different studies. Okay, so at this point, like there is like a whole community of people that are interested in CMV, and one of them being us here, and then there is a group at UCSF with Priscilla and Peter Hunt, and we strongly believed in the story, but we always got the same pushback, right? Like, how do you know that CMV is really the driver, or can it possibly be that just people that are overall not doing well, they just have CMV and develop comorbidity? So, it was our job now to really try to prove the direction of what we were observing. And in 2011, so a while ago, Peter Hunt was able to do a first small pilot clinical trial. And at the time, he used valganciclovir, which is a drug that, is active against CMV, but people don't like to use it unless you have to, because it has various side effects and it's not super well tolerated. And so he did a very small clinical trial. It was less than 30 people, and not everyone was suppressed. But this was the first time that he was able to show that people that were on valganciclovir did have a decreased inflammation compared to people that were not on valganciclovir. This was basically the one milestone that we say, okay, maybe we are in the right direction. Recently, when we started designing the clinical trial that we have been running over the last year, we did go back to those 2011 sample, and we started running some of the soluble biomarker, trying to get a sense about what will be our best primary endpoint, right? And so we did run soluble TNF receptor 2, soluble CD163, soluble CD14. And as you can see, there was a significant decrease in all of this. In fact, based on some epidemiological data, we were able to calculate that if this decrease in soluble TNF receptor 2 holds true, this will translate in a 22% decrease in cardiovascular disease and a 50% decrease in diabetes mellitus. So we were all excited about it. And so we started, engaging with the ACTG to try to design this larger trial. And one important point that everyone needs to know about valganciclovir is that valganciclovir is not specific to CMV. In fact, it kind of treats all herpes viruses. So you did suppress CMV, but you also suppress EBV and herpes 6. And so one of the limitation of this study was that we were unable to isolate the effect of CMV from many other viruses. Okay, so after going through all of the protocol development phase, we ended up being able to start 5383, which is the first large anti-CMV clinical trial in people with HIV, and me and Peter Hunt are the chairs, and Davy Smith has been the co-chair. And basically, we use Letermovir. Letermovir is a drug that is currently approved as a prophylaxis for CMV, mostly transplant patient. People don't use it as a therapeutic. It's extremely expensive. Like, I had even really no idea. I think that for the trial that we designed, which was 90 people, Merck donated 6 million in drugs. Yeah, so it was huge. But what makes Letermovir exciting is, first of all, it has a much better safety profile than valganciclovir, and it's very specific for CMV. And so it will, from a mechanistic point of view, it will be easier for us to really understand what's going on. And So the overall hypothesis or objective of this clinical trial was to assess whether Letermovir therapy for 48 weeks reduced plasma level of soluble TNF receptor 2, which, with all of the data I showed you, we believed at the time seemed to be the most promising primary outcome, and other inflammation and cardiometabolic indices versus no anti-CMV treatment in people with HIV on suppressive antiretroviral therapy. So just to reiterate, why did we choose soluble TNF receptor 2? It's increased in CMV seropositive people, which is the data that I showed you before. There is literature showing that it predicts cardiovascular disease, diabetes, and cancer in people with HIV. We had promising data with the valganciclovir trial, and it's relatively easy to measure. One thing that I learned the hard way is that you don't want to have a complicated flow panel as your primary outcome in a clinical trial, because the primary outcome of a clinical trial needs to go through 1 million very complicated validation points. And I would say it's almost impossible to do with, for example, a flow-based assay. So we were able to find a lab at Duke that was willing to work with us and go through the fit-for-purpose validation for soluble TNF receptor 2. And this is what we settled as our primary outcome. This is how the trial design looks like. We had a group of people that were on Letermovir for 180 milligram every day, and they will continue their antiretroviral therapy. And then we had a no anti-CMV treatment group. So why not placebo? Because it took us so long to go through the approval process with the ACTG that Merck discontinued placebo, and so they were not willing to resume production for us. And so the trial started as a placebo-controlled trial, and it ended up being an open label, no treatment trial, which was a big loss, because obviously that's not how you should be doing a robust clinical trial. And also another lesson learned about being too slow in protocol development, which obviously was out of our hand, because I'm usually not slow and Devi neither, but there was so many, review step and holds up, and it took so long that then Merck is like, well, here is the Letermovir, but I'm sorry, we can't give you the placebo because they closed up the facility. And then after the 48 weeks, we had another 48 to 60, 12 weeks where everyone was followed after coming off Letermovir. So there are some important considerations. First of all, by design, we decided that we wanted to have half of our people with low CD4 T cells, defined as lower than 350, and 1/3 of our people were women. So this made the trial very hard to enroll, because as you know, in the US, with few exceptions, the vast majority of people living with HIV are men, and also a lot of people, thanks God, don't have low CD4 T cell counts. But we believed that it was important because it was the populations that were most likely to benefit from the intervention. Do you have a question? Yeah.
So the gender.
In general, right, we know that women have a different antiviral response, that they have more inflammatory markers in people with HIV, and so we had a hypothesis that women and people with low CD4 T cell count were more likely to benefit. And we also wanted to increase our chance to actually see an effect, right? Because this was still a phase 1/2 trial, right? So we were just afraid if we take everyone is high CD4, we might just wash out the effect. So the other important point is that we were able to secure 4 CD4R1 that were satellites to this clinical trial. We got one R1 to do PET-CT. We got another grant to do fat biopsies. We got another grant to do gut biopsy, and then I got another one to look at reservoir measures. And, because the trial had this appearance to be complicated, and the ACTG started worried that maybe we couldn't enroll it because we were being too ambitious, and we had the women, which everyone is scared about. They made us do a futility analysis after 40 participants. So basically, they said, okay, you can start the trial, but after the first 40 participants reach week 8, you have to do a futility analysis to prove that there is at least some effect. Otherwise, we will just shut it down. 8 weeks. It is, yes. So obviously they didn't want us to be fully powered, but they wanted to see some effect. We didn't like it. And we like it even less now, and you will see why. But that's what they told us we had to do to start the trial. Okay, so this is our baseline characteristic. We had, these are the people that made it to the futility analysis. We did enroll 42, and then we ended up with 39 that contributed to the per protocol analysis. We had a few people that we had to drop out because they were receiving some prohibited medication or just didn't qualify for the primary analysis. So we had 18 people that made it to week 8 on the Letermovir, and then 21 to the no CMV treatment group. And you can see as, by protocol, we were able to get 44% of people with low CD4 T cell and 28 female as defined by sex at birth. So that was I do have to say, like for the study side, it was not an easy protocol to enroll. And we made a slot system because we didn't want, one site to run off with all the men. So basically we had a slot system where people will get 3 slots, and before they get the next 3 slots, they had to show that they enrolled at least 2 people with low CD4 T cell count, and 1 woman, and then they will got the subsequent slots. So also because so first of all, it's fair, and second, you really don't want to end up with all of the men enrolled in Southern California and all the women enrolled in Louisiana. Otherwise, you have so many confounding factors. So I think this is a very important take-home message when we want to do a clinical trial, to make sure that there is representation, to put a lot of thoughts on front about who we want to enroll and what category of people, and incentivize sites so that they can hit their milestones. Okay, the good news was, first of all, Letermovir was safe, and there was really no concerns. So you can see there was some grade 1 and 2 adverse event, mostly diarrhea, headache, that were associated with Letermovir. We had some isolated grade 3 adverse event, but none of them were deemed to be associated with Letermovir by the site doctor. So you can see here, the grade 3. The other important is that Letermovir did suppress mucosal CMV shedding. For every participant, we collected genital secretion, urine, and sputum. And there was a significant decrease in CMV. In fact, it was undetectable almost at every time point after Letermovir, except for 2 time points where we saw a decrease and then it became undetectable. It's important, we didn't have any breakthrough in plasma. That was one of our safety endpoint, because the FDA was worried, what about if we create resistance? But all of our plasma was negative, and we did not see a difference in EBV. So there was no effect on EBV. And here we come to the futility analysis, right? When we submitted our samples and we got the results back, obviously we're very disappointed, because what we saw is that there was a significant increase in soluble TNF receptor 2 in the Letermovir arm as compared to no CMV. And then we ran a second marker just in case that was soluble CD163, where there was basically no effect at all. So we ended up having, to meet with our safety monitor committee, and they had no choice really as to stop the trial because we had some predefined futility endpoint, and obviously we didn't meet them. But thanks God we were able to negotiate. In the meantime, people kept going, right? So we had a decent number of people that by the time this was all done, they reached week 48, and then we were negotiated to be able to follow everyone for an extra 4 week after interrupting Letermovir. So we had to send a letter to all the clinical sites to take everyone off the Letermovir immediately. Thanks God there was no safety concern, but it was futile. At the time we deemed to be futile, and so there was no point in continuing. Obviously, what I really like about Peter, who is the co-chair, and he's one of my mentor, and he's an excellent translational researcher, and he was telling me, at the end of the day, like what is more interesting that when your hypothesis is met is when you're completely wrong, right? Like, now we can think and try to realize why is it going the opposite direction. And if we were not completely surprised, because in the literature, there has been other study that showed that cytomegalovirus was associated, at least in some setting, with improved outcome. These are some of them, right? Like here, there is a paper where it showed that CMV and EBV had the opposite effects on multiple sclerosis, with EBV being associated with increased risk and CMV decreased risk. And similarly to Neurologic, this is a paper from UCSF where they showed that people that were CMV seropositive were associated with a 50% decreased risk to develop neurologic long COVID. And there is also a paper that showed that this is particularly true for older people, right? That people with CMV, when they are young, they have a better immune response to influenza vaccine, and people with CMV that are old have a worse immune response. So it seems like there is kind of an interaction between the immune system, CMV, and age. And it makes sense if you are the virus, because obviously CMV has no interest in killing the host, especially when the host is young. And then as the host gets older, they probably don't care so much anymore. But really the primary idea of CMV is to spread, right? This is why it replicates in semen, and this is why it doesn't like to kill its host. Okay, so the other, so thinking deeply and doing some review, we came over this interleukin-10. So interleukin-10 is a very interesting cytokine because it gets induced with inflammation, and then it has a loop effect and it decreases inflammation. It's important. It's kind of a defense mechanism of our body, because when you start having inflammation, you don't want to go wild, right? Otherwise, you die, you go in a cytokine storm, right? So you need to have some breaks. And interleukin-10 is one of these breaks that the body can use to modulate inflammation. And both EBV and CMV have viral IL-10. Basically, the virus is able to encode a homologue IL-10 that is very similar to the human one, but is not exactly the same. And the EBV IL-10 is a partial agonist of the human IL-10, so it's weaker, while the CMV IL-10 is a super agonist. So it basically has a similar effect as IL-10, but much stronger. So we were thinking, what about maybe that's what happened, right? When we suppress CMV, we suppressed via IL-10, and because via IL-10 has such a strong effect, maybe this is what happened. It's like taking your foot out of the break. And then inflammation went wild, at least at the beginning. And so we did measure IL-10 receptor and human IL-10 in the clinical sample. We also tried to measure viral IL-10, but we were unable to measure it in plasma, which is not surprising because the virus really didn't replicate in plasma. But what we see here is there was a significant decrease in IL-10 receptor with a stable human IL-10, which for us was an indirect sign that maybe the viral IL-10 was at play. So, and here we also designed a very nice figure, Peter and I, to try to explain it, how, you have a CMV infected cells that generates both the the CMV virus, and the immunoregulatory CMV IL-10. And it looks like CMV has really kind of very sophisticated way to interact with the immune system. On one side, it does like to increase inflammation, but on the other side, it also likes to decrease at least some inflammation and decrease antigen presentation. That's his way to hide in the body, right? So when you stop CMV replication with Letermovir, you affect both of these mechanisms, right? And so there will be some of the inflammatory markers that go down and others that go up, depending on which of the two arms they are mostly engaging with. And so our hypothesis is that suppressing viral IL-10 is like taking the foot out of the brake of the immune system. So when we ended up, getting all of the samples and we measured all of the sample up to week 48 and past, you can see that that's exactly how it looks like, right? You do see there is an increase at the beginning here, but then there was a significant and steep decrease in soluble TNF receptor 2 up to week 48. And it does seem to stay down at least for a while after interruption. We had about 40 people that did the whole clinical trial. So, we have a decent amount. Obviously, we're not powered like we were hoping at the beginning. So we had very similar pattern with CRP, interleukin 6, and D-dimer, like going up and then down. We also had some marker that went down from the beginning. One was interleukin-1 beta, which I mentioned before. So, and it's strongly associated with cardiovascular disease. There was a steady decrease from the very beginning, and some increase after Letermovir was interrupted. And then we ended up running full proteomics just to take a more comprehensive look. And you can see like there was more than 30 markers that were decreased in the Letermovir arm. And many of them were associated with endothelial dysfunction, with inflammation. So in reality, Letermovir had a big effect on the inflammatory system. We just had this futility analysis that was probably too short, and we were really unlucky. We measured the wrong marker. And we were also really excited because there was a recent paper where people this study team used the Mendelian randomization statistical methods to try to find some marker that were independently associated with cardiovascular disease. And they found 5 hits, and 3 of them were, decreased in the Letermovir trial. So, and this was a completely independent cohort, but it kind of really showed nice overlap because we measured hundreds of markers, but it looks like from the 5, 3 were overlapping. Yeah, and here is the data from the Letermovir on these 5 markers. We also looked at CMV-specific IgG titers. Interesting to see they declined during the entire 48 week, and then they started to increase after Letermovir was interrupted, despite the fact that we didn't find any CMV even after. So it looks like probably the virus was trying to come back, and so the immune system was sensing the virus, and so the antibody were going up, but the virus was still suppressed. We were also looking at the CD4-CD8 ratio, which in people with HIV is a very important marker that has been associated with morbidity and mortality. We know that people with the higher CD4-CD8 ratio do better, and that's a better marker than only looking at CD4 and only looking at CD8. And you can see, again, there is an increase a very significant increase, and then it's going down again once we interrupt Letermovir. There was a big sex interaction that's obviously we were excited about because we hypothesized that women will have a stronger effect, which ended up being true, despite the fact that we only had 4 women. Still, right? We still saw a significant effect. When what was interesting to us is that the improve seemed to be driven by an increase in CD4 T cell count. This was particularly true in people with low CD4 T cell, and this is very exciting because so far there is really no good way to bring CD4 T cell up in people that are low responders. So this gives a lot of hope because low CD4 T cell in people with HIV is just a bad prognostic marker. And after these people are on antiretroviral therapy, there is no good intervention. And then we also had some functional assay tests. We did the 5-time chair raise test. This is a kind of a very short way to look at physical function, is that when the patient comes in, you ask them to basically stand up and sit down 5 times, and you measure how long it takes. And it's a pretty well accepted measure of physical function that people use, to look for friability. And we were surprised ourselves to see that there was a significant decrease in chair raising test in people on Letermovir. And there was also a very nice correlation between the change in chair raising time and the change in the inflammatory marker, as well as the CD4-CD8 ratio, which seems to be part of the mechanism. Okay, so just to conclude, Letermovir improves immunological and functional aging. We have been looking for a promising intervention in the field for a very long time, and so there is a lot of excitement. Now, I did present this data at CROI, and the whole Merck was there, and now they actually reached out and they want to redo the trial, and they are ready to give us another 6 million of Letermovir, which at the beginning they didn't really like. Now, obviously, we will have to see if the AIDS clinical trial group survives the Trump administration, because that's a trial that we would like to go back and run as part of the network, because we did it once. It will be much faster and easier to just restart the same trial. Basically, to summarize, Letermovir seems to have a durable suppression of CMV shedding. There was an transient increase in some inflammatory marker, but then there was a sustained decrease over 48 weeks. There was an improvement in CD4-CD8 ratio and CD4 T cell count, and also an improvement in physical functioning, leg strength. And it looks like people that with low CD4 T cell count and women seem to benefit particularly from this intervention. And obviously, the clinical benefit implications are unclear, but we do believe that this is probably the most promising immune-based intervention yet for treated HIV. A few additional interesting considerations is that the fact that CMV seem to stay suppressed even after we stop Letermovir. Obviously, the mechanism is unclear, but this could have consequences to maybe have a pulse therapy strategy so that people don't have to be on Letermovir forever. We know that Letermovir is very expensive, but as it happened in the past with other drugs, like when the market opened up, the company finds way to reduce the cost. There are some obvious difference between Letermovir and valganciclovir that we still need to study, as I think that the fact that Letermovir didn't suppress EBV might be a good reason why the valganciclovir effect seemed to be different. There is a risk of whack-a-mole effect, right? That when you target something else pops up. So maybe targeting CMV is just a safe way to reduce IL-1 beta and IL-6 without having the adverse event that we saw with the early trial. And one big lesson learned is that the futility analysis at the time was not the optimal approach, at least not how we did it with one biomarker that was a hit or miss. And then, I have a lot of people to thank. This was obviously a very long journey, and This is me and Peter when we were presenting the data at Troy and Davy as the vice chair, but then really all of the sites and the investigator that have helped set up this trial and hopefully will help with the next one.
Oh, thank you, Sarah. All along as I was sitting here, I'm thinking, is our therapy right now, does it have at least a few protease inhibitors? And do we have an anti-HIV part of it? Does it have a protease inhibitor as one of the base?
Some of them, but not routinely, not anymore.
So my question why is because I've thought about this for a while about the aging complication and atherosclerosis in HIV with or without treatment. And there's this extensive literature about protease inhibitors really messing up lamin A, the nuclear membrane protein, creating this backlog of prelamin being produced, which is known to advance atherosclerosis, coronary artery disease in the immune cell, messing up the NF-kappa B shuttling in and outside the nucleus. When you said that question, there must be a link somewhere between inflammation, aging, coronary artery disease, CMV, HIV. What occurred to me is, well, of course, because CMV, when it's shuttled out, it destroys lamin A. And we all know progeria, which is accelerated aging, is nothing but lamin mutation. What, if anything, do we know is the interaction between CMV, its infection, presence, being on protease inhibitors or not, and then whether its eradication can be, if it had subgroups in the prior literature to look into whether there was some of that literature has few on protease inhibitors, not other patients, if there is something there to learn. Sorry.
No, that's a good point. No. That's a good question. And I don't think that we know if there is an interaction between proteinase inhibitor. And I think that we do know that some class of antiretroviral have a negative effect on cardiovascular disease. And this is one of the reasons why people have been gone off, like one of the reasons why, drug development keep going. And now most people are on integrase, right?
Yeah. The data on the protease inhibitors never really played out. So there were other things that were going on. Now, the question about lamin is a good one for CMV. I don't know.
Yeah.
Yeah, just outside the nucleus.
No. That's a very good question. The spectrum has been studied CMV for a long time. He had the connection between fractalin, who is like this protein on the endothelium, and CMV specific T cell and how they interact. So I do believe there is some interaction at the endothelial level where CMV, like that is independently of only CMV destroying it. And a lot of people are looking into it, and it's probably more complicated as everything with CMV. But thank you for bringing it up.
Two minutes for one for you.
Oops.
There's
Yes.
but there's what you're asking is interesting, but there's a founding issue that at the same time that we started dropping the recent years, we started dropping our more mitochondrially toxic nucleoside. So there's a combination of this. So it's going to be hard to tease out protease or if it's changed just overall. So my question for you guys, super interesting. Do you guys look at CMV specific cells and everyone in your?
Not yet.
Okay.
Like we only did the IgGs, but we will. So we are doing all of the hardcore immunology.
Yeah. You looked at
Yeah.
I really enjoyed that. Really fun to see the whole story. Inspiring to see it something at the bench. You're able to bring this forward. So thank you for sharing a lot of the struggles. I know you did proteomics. I was wondering if you did any other omics approaches to see what's upstream of the IL-6, IL-1 beta that might be impacted specifically on their antiviral signaling pathways that were altered by treatment.
Yeah, and we are working on it. I know that there is a collaborator of us at Vanderbilt that is doing metabolomics, and we are doing all sorts of single cell RNA-seqs We don't have the data yet, but yeah, we plan to do a lot of, like we have the samples now. So there is a lot that we can learn, right? Really, even if it kind of failed on one side, on the other side, there's a lot to learn. And, I am really proud of how, we were able to then make a compelling story and go back to Merck. At the beginning, they said no, because they are really focused on the transplant. And they didn't see a clear rationale why they should invest more in HIV. But when they saw this data, it was pretty convincing.
To your question, there is some interferon pathways that are very specific around CMV, and we think that that might give us telltale signs.
Yeah, so it was a Sunday. Very interesting. DNA. HIV side is interesting. There were drugs that it would get interferon tests, and then the virus itself, and also the drugs.
We also have anti-CMV vaccine trial that started almost together. And now we just ended week 72. So we are getting those samples. I'm very curious to see how that pans out. Yeah.
Not fun. And then the second question, would anybody prescribe either a rich person who could afford it, who's a woman who supposed to be born?
We had, honestly, like, I don't know if I will do it yet, but we did have a woman in San Francisco who was on Letermovir and had the CD4, like she was a non-responder her entire life, and then she went on Letermovir and her CD4 shoot up, and then she had to stop it because of the futility, and then her CD4 turned down, and she was really bummed. So I don't know if I will do it right now with only this data, but I do strongly believe that if we can repeat the trial and we can confirm this, it could be a huge milestone, life-changing type of intervention in people with HIV.
And you can prove the data.
Yeah, I don't know if Merck will, so we need the ACTG to fund the trial. I don't think so, unfortunately, because Merck is not producing the placebo, and that will be the only, yeah, we have to discuss with the ACTG. Over encapsulation is expensive and it makes this pill hard to swallow. So there is always a little bit, it will be much better to have placebo. Yeah.
So you buy other things.
Yeah. We do have. Yeah. Liz.
Basic. I was wondering if you have this objective method. Subjective, subjective. You have objective fit test. Just like in patients respond to medication.
We might have some of this that we haven't analyzed yet. I'm not 100% sure if we ask them. Well, in reality, no. Wait, I'm sure we asked about fatigue as part of the safety, and it doesn't look like it popped out because I think the only three is diarrhea, headache. Yeah. 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 But the safety profile was excellent, really. Like, yeah.
That seems to be low CD4 count rates with this anti-CMV treatment. Could it be true that those with the highest viral load at the start of the trial would also be the most likely to benefit as well? Viral load being CMV, and in fact, you do see a difference between the baseline CMV levels of the two groups.
Yes, right. We did see that CMV went down. I don't think we are right now powered to stratify response based on CMV. And we discussed at the beginning, right, if we should even have CMV shedding as a pre-screening, but then we decided against it because it's so intermittent. And we know based on our own data that you can shed today and stop shedding tomorrow. And so we decided it was not a good way, but I think that that's a good point. In fact, it's probably true. My takeaway from this is that we need better CMV.
He hasn't made many in decades. I mean, Letermovir is one of the first ones that's come out for a long time, and now they're able to charge a lot of money for it. So if you have any ideas about making new CMV drugs, let us know. Where it's going.
But they are. See the Turkey one, but it's still not. No, people.
We sometimes use it for therapy, but it is, that is how they set up their trials, and that is how they got the best indication. And then that's the one they went with.
I think they did some concern about resistance.
We did the resistance studies here, and you can get resistance in treatment with somebody with bone marrow transplant who's very immunosuppressed. And that kind of put the kibosh on what they would do, but people still use it sometimes for treatment.
If it's less toxic than.
Yeah, it's less toxic. People can have a lot of diarrhea, and sometimes it's difficult in a post-transplant place where they have lots of CMV going on to sort of delineate those issues, but it's absolutely great. Okay,
Thank you.
thank you very much.